Après-midi. My name is Marilyn McDonald, and I'm from the School of Nursing at Dalhousie University in Halifax, and I'm a member of the Research Management Committee for the Canadian Frailty Network. It's my pleasure to open this session this afternoon and to introduce our presenters. So this afternoon, we're all about aging in place, settings of care, and interaction. Older Canadians want to age in the setting of their choice, whether that's at home, in long-term care, or other options. This third block of presentations will provide insight on initiatives that support aging in place, that work to make hospital experiences more age-friendly, and that improve long-term care. Throughout these presentations, the importance of interaction in healthy aging will be demonstrated. And of course, we've begun now and we continue until 3:20, at which time we'll take a break. We open this afternoon with Jennifer Dobbelsteyn and Donna Augustine. Eimeg, tleiaoltieg. We are home where we belong, home for life, life-supporting independent living for Elsipogtog Elders. Followed by Heather Higgins, the integration of a nurse practitioner into the rehabilitation and reablement care team for vulnerable seniors. Suzanne Dupuis-Blanchard, nursing home without walls for aging in place. Jennifer Peterson, frailty-focused enhancements to seniors hospital care, the Fresh Care Project. Ali McGill, mapping and modeling complex healthcare processes for older adults using the functional resonance analysis method. Vicki Muscat, Shannock's Insights Lab, putting our data to work for long-term care. Alicia Gadet, scaling up a palliative program in long-term care project. Donna Miller-Wallace, Meet the Waltons, and Corinne Hersey, Garden Project. So take it away, Jennifer and Donna.
Well, good afternoon, everyone, and thank you very much for coming back from lunch. We're glad to see you all here. I'm Dr. Jennifer Dobbelsteyn, and this is Elder Donna Augustine from Elsipogtog. And before we start our presentation today, I would like to do what's customary before an opening prayer, which is to offer tobacco to Donna for doing this opening prayer for us today.
Oh, well, thank you. Aho, ningato sisi miktiche biteluisi. Ni mega mewisk. I just told you my language, my spirit name is Thunderbird Turtle Woman, and Migama. So this tobacco is very considered very sacred to our people. Never smoked cigarettes in my life, but it's actually, when you present that, it's an offering to your spirit. And so I'm going to hold this tobacco and I'm going to say a short prayer to give thanks for today and everything that the Creator has provided us. Sometimes we forget to be thankful. We have so much to be grateful for. And I'm going to offer that prayer to the Creator, the spirits of the four directions, and the earth, which we call our mother. Because Mother Earth sustains us, gives us everything that we need. Agisog, walaliko chikisko, dandel mawaliek. Ni wada megnego, dandel yankwewiek. Ito wakta megisuk tepi aitem sukoi. Walaaliek kisuk. Nego, dandeli, nurian tasma amino. How chibanuk chamishan leoto nadil. Walaaliek. How apkadesnuk chamishan leoto nadil. Walaaliek. Ha etkasnuk sa watimiskish na'i. Walaaliek. Ha o adnuk chamishan leoto nadil. Walaaliek. Ha gishnimamiko. Walaaliek. I've said nogama, for we are all related.
Thank you. Thank you, Donna, very much. Our presentation today, and Marilyn did a very good job with the title, Eimeg tleiaoltieg. We are home where we belong, home for life, supporting independent living for Elsipogtog First Nation elders. Where is my clicker? Do you see it? Oh. Okay, this is going to work, I think, I hope. Yes, look at that, amazing. Okay. I would like Donna to talk for a moment about reconciliation and what reconciliation means. This sets the context for our talk because this is really a reconciliation project. And as you know, there were 94 calls to action in the Truth and Reconciliation report. And we believe that our project answers some of those calls to action. And Donna?
First of all, a little bit about the River of Fire. When we were first contact, we're from the east. So when they were going down, the ships were going down the rivers, especially at night, on both sides of the river, along the Elsipogtog River, all the way down to what was formerly called Big Cove. Our people would be camped with campfires all the way, so it was all lit up. And so this is one of the reasons why it came to be called the River of Fire. Also the beautiful sunsets over the ocean. And so reconciliation, we are now living in a time of reconciliation, but truth has to come before reconciliation. So we hear about the truth, the true history of this land, of the first people of this land. Unfortunately, the true history has not been taught in schools. And so you need to, there needs to be a coming together to learn the history about one another, to form good allyship. Because here in New Brunswick, we are covered under the peace and friendship treaties, where our ancestors and your ancestors, nation to nation, agreed to live side by side in peace and friendship. And reconciliation is not just about talking about something, but actually doing something. And so I'm just very happy to be here today. To me, this is part of reconciliation, that you, our people are up here being honored and being remembered, and just valuing what we have to offer.
Thank you. Okay, I'd like to make mention of Eva Sock. She couldn't be here with us today, but she is the co-primary investigator with me on this project. This project wouldn't be here without Eva. She is Director of Primary Care at Elsipogtog Health and Wellness Center. And she is an amazing woman, a social worker. She represents all Indigenous people in New Brunswick on the New Brunswick Health Council. And she started this project with a question. What do our elders need? What are their issues? How can we get at these? How can we find out about them? And then what can we do about them? So she invited me to come to Elsipogtog and collaborate with her. And the collaboration started that day, and it's continued throughout. So we did receive the grant through the Healthy Seniors Pilot Project from the Public Health Agency and administered through the Aging Secretariat and METCU. And the project began in February. So just quickly today, we'll talk about our objective in the project, the milestones, the findings, the new programs we implemented, and the assessment tool. This Home for Life assessment tool would allow us to go to any First Nation community in Canada and do a quick glimpse at where they stand in terms of home for life. What are the strengths and weaknesses in the community in terms of keeping elders home, with a 25 question survey. And we have developed that and tested that, so it's ready to go. So I'll talk about some results we have from that late in the presentation. The next steps, and a thank you at the end. So the objective, just quickly, the objective of this research was to explore the needs of elders living at Elsipogtog and understand the services and support they need to continue to live in their own homes and in culturally appropriate settings, very important. So the milestones, really, in my mind, we've had several objectives, but we've had three main milestones. We've had conduct the research, use the findings to implement new programs, and we've implemented new programs, and then develop the Home for Life assessment tool so that this project is scalable elsewhere and can benefit Elsipogtog even on an ongoing basis with using the tool twice a year or once a year to check progress and where things are. Already from the tool, we have seen a difference in the initial data collection, which was right at the start of COVID, and the situation now, which is after the community's been given money for COVID relief, for food and things like that. So I'll talk about that in a minute. To conduct the research, we had to ask the right questions to the right people in their own language to get the answers to the questions. Sorry, I'm in and out here. These people you see sitting here to my left are a wonderful team. They're some of the members of our team. And These ladies learned how to do research. We had several education sessions to teach them about what needed to be done and in-depth interviewing and those kinds of things. And they were given help with data collection tools and data collection booklets and encrypted coding to make sure everything was confidential. It's a small, it's not a small community, it's 3,500 people, but it's a small world that you need to make sure of confidentiality. And they stood up and they stepped up and they made me proud, because as a researcher, I stood in the background and they asked all the questions to all of their community members, and they did a good job documenting the answers, and they're pros now. The elders felt safe. They felt safe with this process, and we received rich data as a result. Findings, Donna's going to talk about the findings, and these are some quotes. And again, we're going over this quickly because we just have 10 minutes, but we have a whole document on findings that's quite lengthy.
It pays for me to talk fast, right? First of all, I just want to tell you very quickly, I feel that this is very important. In Native culture, elders are highly regarded. Once your hair starts to turn gray, you have earned that right to speak. And so you're valued for the wisdom, for your life experiences. I just want to say that. So the findings, that's why I have this over here. On food insecurity. These interviews were done in 2020. There were 5 key findings. So you have it right there? Yes. So the Meals on Wheels will be nice for people living alone who cannot cook for themselves. Meals on Wheels, we should have it here. We didn't have that. Other findings on housing, poor housing conditions. The house is pretty old and needs some repairs. Cabinets need repairs, laundry room is downstairs, and the bathroom is way too small. We need help with maintenance, stuff I can't do anymore by myself. I have to rely on someone else, even cleaning the yard. The findings on loneliness, that's very important. No one visits. No one cares to visit or check up on me. I'm very lonely. I miss my mom, my dad, and my late spouse. Everything was okay when they were all here. Now, fear, safety, and security. I keep the curtain closed all the time, scared that someone is peeking in at night. I'm worried about everything, worried about children and grandchildren. I pray for the teenagers because of drugs and alcohol. I am scared of someone coming in at night when I am alone. Other findings, lack of continuum long-term care, supported living center. Would love to see our own nursing home on our reserve. This is so important, so key, because we know our own people. We know what our needs are. Would love to see our own nursing home on the reserve, or maybe an assisted living home. It would be nice if my grandchildren can walk and come visit with me and talk to me in my language. The ones that are taken on the outside of the community, really, they almost basically die of loneliness because they're away from their community. And we're very family oriented, we're very community oriented. I would want to be in a nursing home. I would love it if we had it here, if we had enough trained workers and to create jobs. If we had a nursing home here, we can speak our own language and our own people can take care of me. I would move into a home. They would also have their own food, you know, they're accustomed to our own food.
It's teamwork here. So the programs that we have implemented to date based on the findings, the first program is called Meals to Go, and it was like a Meals on Wheels, but it was different. It was curbside pickup in keeping with the times we were in, and a restaurant in the community provided the meals. So we fed 70 elders twice a week on Tuesdays and Thursdays, and the team organized how people would know if there was a change. For instance, if there was another event in the community, the meals might not be on Tuesday, they might be on Wednesday, things like that. So there was a lot of coordination between team members and the staff at CC's Entertainment Center that did the meals for us. And we did educational programs that we call Eva's Vision, and those programs related to dementia care and Indigenous perspectives on dementia care, which are different than non-Indigenous perspectives on dementia care. As a nurse, I came to the community thinking that dementia was dementia, the dementia that I knew about as a nurse, but it's different in First Nation communities. And Donna told me that, and I listened to her. And we did a literature review to find out about that, and we shared education in a way that suits people in the community. It's almost thought of as a circle of life, that you're going back around to the beginning of your life. And the care is gentle already. We did put the gentle persuasive care program in, but one team member said to me that she saw a lady in the middle of the road, and she stopped her car and got out and just went over. She knew the lady, and she just kind of helped her and talked to her and got her into the house. So, I mean, this is dementia care, and it's in a different, loving, understanding, careful way. So I've seen and heard many approaches to it that are quite impressive in the community. Now we'll talk about the assessment tool just quickly. And it's an evidence-based assessment tool. It has 5 components, and there are 5 questions for each component. And we used a 3-point Likert scale. I'll tell you a little story about the Likert scale. I, as a researcher, designed it as agree, disagree, or neutral. And everything we do, we run by our team. And I said, if there's anything you'd like to change about the assessment tool, let me know. And they said, we'd like to put yes, no, or maybe. So this is what will speak to the people that are answering the tool. So that's what we did. So we'll go to the next slide. Yeah. So the first one, food insecurity, the results are shown for 5 statements. Eat meals 3 times a day, balanced diet, can afford monthly food, can get help to buy food, and skipping meals, which is unfortunately, a common thing that happens with the elders in the community. Meal skipping is prevalent, 50-50 response. Comments are telling. For instance, balanced diet, fruits and vegetables are expensive, and I'm on a fixed income. So this food insecurity pie is showing you better results than what some of the comments. We also asked for qualitative comments. Since I'm a qualitative researcher, I like that to get detail behind the numbers. And as I said, this was done recently. It was done in April. So there's been some relief money come in for food. So that's why the numbers are looking good on the right-hand side. But this reflects all 5 statements and not, we do have the charts. We have a 45-page document on this particular thing that Haley put together. So this is just a quick peek at it, really. Go to the next one. Yeah. Loneliness, 5 statements. Family visits regularly, have family friends to talk to, have someone to check on me, friends to go on outings with, and content on my own, not lonely. 60 to 70% agreement with all 5 statements. Comments revealed a desire for more visits from family. Nobody visits me. I have to call and beg them to come. And if I was sick, they would come, but I really don't want to bother them. Also, when I was able to, I love being alone. Now that I can't go anywhere, I want company and I'm lonely. Ironic. Poor housing conditions, also important. 5 statements. Thank you. We're almost finished here. 5 statements here. And I can't see them. House is in good condition.
I might have given you the wrong slide, sorry.
That's okay. Anyway, I'll just go to the results here. This was very problematic. Yes, just take a look at the slide. It's sad to see, but there isn't a system to address home renovations really on reserve, and it's showing, and it's resulting in illness and sickness in the community. So it's a serious problem. We'll just go on to the next one, I think, Donna. Right. Yeah. Fear, safety, and security. Again, there were 5 statements this is based on, and it's also very problematic. The elders are afraid at night, afraid to leave their house. on their own, and 50% do not want to say in general whether it's safe in the community or not. So that's a telling fact. Issues raised include break-ins, dogs running free, drugs and alcohol issues in the community, and cameras, deadbolts, and motion lights. Continuum of care. We'll finish with this one. This one, there were 2 questions out of the 5 statements that were 100%. And those relate to want a facility to live in of some sort in the community where people speak our own language. So that was so strong, and that makes this 92% or whatever. I think it's 92%. Okay. Yes, next one. What's next? We'd like to do a train the trainer program to teach Indigenous healthcare providers in New Brunswick First Nations to use the assessment tool. And this would require additional funding in the future if we were to do that. And the closing statement I'd like to make is we can't ignore the long-term care needs of Indigenous elders anymore. There needs to be a continuum of care. They must age in place in their own communities. We must build a continuum of culturally sensitive long-term care, and people need equitable, dignified, and healthy aging. And the big thing that Donna said, elders have spoken, and now it's up to us to listen. Next. Thank you, Elsipogtog Elders. First and foremost, community-based research team, Elsipogtog Health Managers, Elsipogtog Chief Aaron Sock and Council, Jane, April, and Nabila from METCU, big help. Leah Carr, Brittany, Lester from CFN. Thank you to all the conference participants for your interest in our work. And Donna's just going to do a quick, short song for us, and then we'll finish. Sorry, we're going over a little bit here.
It's very important to our people that we have to be in balance. We can't just talk about serious things and not do something fun. So for all of us, for our spirits, we need to just feel good. So I'm going to sing a friendship song. But what I'd like to do is to invite all of you to sing it with me. It's very, very easy. It's a chant. There's no words to it. So I sing the first part. It's called the lead. And the second line is exactly the same as the first. So don't be shy. I want to hear you, okay? Including our team, including you. I never heard Jennifer sing yet, but and our people really love Jennifer. I just want to say that. And Haley, once you're accepted, you know, by the elders, by the matriarchs, really, especially. We are a matriarchal society. Then everybody will accept them and trust them. So thank you. I want all of you to be happy. Try it. So I'll do the lead again. Okay. Okay, now we're all going to do lead together, okay? And I want to hear you, okay? Now you know a friendship song. Thank you. Thank you so much, all of you. And to me, I just want to teach you one word in our language. To me, this is the most important word in any language, how to say thank you. And so in our language, in Mi'kmaq, we say, welalin. Well as in being well, la as in the first part of a French word, and somebody named Lynn. So welalin, welalin, welalin to all of you. Oh.
All right. Hi, everyone. So my name's Heather, and I'm a project coordinator with the extramural program over in St. John. And I have the pleasure today of introducing you to our Healthy Seniors pilot project titled The Integration of a Nurse Practitioner into the Rehab and Reablement Care Team for Vulnerable Seniors. So I will set out with a bit of a context piece, just where it might not be everyone who's familiar with extramural, but some people might refer to us as the hospital without walls. And you may recognize the little blue cars out in your community. That's our team. We've been around for about 40 years. We go and we provide home health services, clinical health services to all New Brunswickers of all ages in their homes all across the province. And this program, the extramural program, has actually been recognized internationally as an innovative way to support comprehensive healthcare needs. And this is in large part, I believe, due to our team. It's the people. We have an interdisciplinary team with a wide array of skill sets. We have registered nurses, licensed practical nurses, respiratory therapists, occupational therapists, physiotherapists, registered dietitian, rehab aides, social workers, all sorts of skill sets out on the road, visiting our patients out in the home. So we're all about enabling that aging in place. So within extramural, we actually have kind of a subset or a little program within the extramural program, and we call this Rehab and Reablement, or R&R for short. Again, these are some terms I'm not sure if everyone's familiar with, so just to put everyone on the same page, rehabilitation or rehab is all about maximizing recovery for that patient, and this is accompanied by reablement, so helping that patient learn or relearn a set of new skills with maybe how to learn with that new impairment. So lumped together, we call this R&R. It's a pre-existing approach to care, and it's geared for seniors 65 and over. And we go into their homes post-injury or illness, and we provide intense short-term services to support them. So we're in the home within usually about 48 hours once they've been discharged, and it's a 9-week program. And along with our extramural interdisciplinary team, we often have homemakers in the homes as well to support these patients get back on their feet. So it's all about empowering that patient to continue to live at home in a safe manner. So with the success of the extramural program and R&R as well, we still do see some gaps in care, of course. And the gap I'm going to talk about today is meeting these vulnerable and frail seniors' medical needs in the community. So if we think about who this R&R patient population is, they're 65 years old or older. They've just recently had, maybe it's a stroke, maybe they've had a fall, maybe they have a new diagnosis of dementia or diabetes, and they get home. Often these patients do end up having an urgent health issue that requires attention. They need support. And we know it's not everyone who can access quick and timely primary care support. And it's not always the case for these often homebound patients who are able to have the support of a primary care provider come into their home environment and offer that assessment. And of course, it's not everyone who has a primary care provider, especially here in New Brunswick, we know this. So if these medical needs cannot be managed in the community, these patients often do end up frequenting Emerge. They need to be readmitted if their medical needs can't be managed at home. So in order to address this gap, the St. John unit with extramural is integrating a new health discipline onto our already great integrated team with many, many health professionals. So we're introducing the nurse practitioner to our team. And the nurse practitioner is going to be able to see these vulnerable seniors in the home or special care homes. And for those who maybe are not familiar exactly with what a nurse practitioner is, they are basically advanced practice registered nurses that have that ability to really offer that primary care lens within the home. They're able to diagnose certain diseases and disorders. They're able to order diagnostic tests. They're able to prescribe medication. So it's that enhanced scope of practice. So within the R&R program, with extramural, our intention is to have our nurse practitioner actually get in the homes at the early stages of R&R to make that assessment once they're home and to give them that support right off the bat, right at the start of the 9-week program. So by enhancing the current model that already exists with extramural and R&R, our goal is really to provide that timely and appropriate primary care in the community for R&R patients in their home environment. We're looking to ensure the care team at extramural feels supported in having a nurse practitioner on their team. They're able to collaborate very easily with them. And of course, we're looking to improve access to the R&R program itself. So I should mention our project is still, in its early implementation phase. Our nurse practitioner couldn't be here. She's out on the road seeing patients. So all is moving forward towards working towards these goals. But hopefully we are still looking towards these future implications. So we do expect and hope to see an increase in the variety of patients benefiting from R&R. And this would be, of course, due to that enhanced scope of practice that we have on our team in the home. And again, looking to provide that extra support for our already existing extramural team. And with that, we're also looking to see some reductions as well. Looking to reduce the length of stay for R&R patients in the hospital. We're hoping to get them home sooner. And we're also hoping to reduce emergency department visits by these patients or hospital readmissions. Again, all about that enhanced scope of practice and having that primary care lens in the patient's home. So in terms of next steps, again, like I said, our nurse practitioner is out on the road, so we are in the implementation phase. And there will be an evaluative component tied with this project, of course, and those results would be coming later in the fall, so please stay tuned. And I look forward to those results and look forward to seeing more nurse practitioners more widely across the province with our team. So if you have any questions, please come find me at my booth. We're at the far wall.
What great work being done. This is so impressive. Thank you so much to CFN and NBHRF for putting this on. It's wonderful. Yes. If we could all put those wonderful results and those wonderful projects all together to benefit an aging New Brunswick, it wouldn't be great. So thank you. I'm glad to be here to be able to talk about Nursing Home Without Walls, Foyer de Soins Sans Murs. I will do my presentation in English for the benefit of everyone, but we do have a booth in the corner against the wall there, and we do have both English and Francophone. So this is, again, like everyone else almost, an HSPP funded project. It was actually one of the first ones to be funded. And so we have the privilege of having this ongoing project for the last few years now. And I'm here to talk about the results a bit of what we're doing. This is very much a community-based project. I may be the one who's here right now speaking about it. The team is out back there and some more in the corner. And I have to say, without these community partners and the local communities believing in this and wanting this to happen in their local communities, Nursing Home Without Walls would not exist. And so I really want to mention Westford Nursing Home, les résidences Inkerman, les résidences Soutien Saint-Don, Manoir Edith Pinette, and the Nursing Home Association for their continued partnership. So why Nursing Home Without Walls? Our past work looking at aging in place, really confirmed the need to intervene to try to keep seniors at home. We've heard since this morning many of the factors that prevent seniors from being able to age in place. We've talked about exercise, we've talked about medication. We've also talked about how it's not necessarily medical needs, but mostly social supports, socialization, transportation, and many other aspects. That was also what our research was confirming for the last while, I guess. And we were looking also at the fact of the language factor. So aging seniors in St. John, Fredericton, and Miramichi who speak French and who are in minority communities, but also Anglophone communities as well. And I have to say that the results were pretty much the same. We also have to realize that in Canada, including New Brunswick, the majority of seniors are in the community. 92% of adults over the age of 65 are aging in community outside of institutions. And so we really have to focus on trying to support them to age in place. Most of their needs, from our experience, there are medical needs, of course, hence the extramural program and all the wonderful work that's being done. But a lot of it is on what I call social health. And in a brainstorming session, who knew that we would be here a few years after, of saying, what's in those communities that already exist and that we could benefit on and provide aging in place supports? And we started thinking and said, well, nursing homes are in many of our communities. Why couldn't we do something with the resources that are in place or the structure that's in place, but add resources to it and help them provide extra services for seniors in their communities? And that's exactly what Nursing Home Without Walls is. It's almost, I had to laugh when the previous presenter said extramural was a hospital without walls. Well, this program of aging in place belongs to the nursing homes, but we've eliminated the walls so that they reach out to their communities. The pilot project is happening in 4 communities. It is happening in 3 Acadian Peninsula communities of Eimeg, Inkerman, and Paquettville, and also southeastern New Brunswick in Port Elgin. The goal, the large goal of Nursing Home Without Walls is to provide access and appropriate supports to seniors to age in place. We also have, of course, some objectives around that, and that includes access to appropriate information and services, social health initiatives to counter social isolation. We heard a lot from community seniors and their families that yes, aging in place is the goal, but there was also a great concern about social isolation and loneliness. And so we really wanted to address that. Also increase knowledge on health issues that can support aging in place, as well as empower the local communities to respond to their aging population. Many of the communities in the pilot project have about a 30%, even some 35% of their communities over the age of 65. So Nursing Home Without Walls, what we've been doing, and I've put that umbrella there because as we continue our work in this and that we start talking about it and explaining it in different terms as we learn from what we're doing, I think we've come to realize that Nursing Home Without Walls is an umbrella term where underneath that we can add or subtract or modify, keep it flexible to answer to the needs of the local communities with whom we're working with. So right now, what we are doing is providing services to help coordinate or navigate the system. I really don't want to use the word navigation, and we're trying to pull away from that because we're doing a lot more than navigating. We're really accompanying seniors to be able to find the services. Many of them have said the services are there, we just can't access them. We need help to access the services. And so we've gone from providing general information about all the good services that exist, government or non-governmental, to individualized information through home visits. And some of them, you know, once empowered, once they have the information, can go on and access the services. But others really need that accompaniment of helping with the forms and the follow-ups as well. We were hearing a lot about seniors who said, oh yeah, I applied for that 6 months ago, never found out anything about it, didn't follow up. No, I guess I don't qualify. But something was missing maybe in their file, or there was just no follow-up done. So we're helping with that. We're also providing what we call social health initiatives around group activities, be it exercise, but also very much social, crafts and singing and things like that. The friendly visits and calls. It looks so simple to say, oh, it's a friendly visit, but so much happens during that friendly visit. Intergenerational activities partnered with local schools, with local universities to provide social visits, to provide meals together, not just drop off a meal, but also enjoy a meal together and have that conversation between generations. Caregiver respite as well, and having volunteers come into the home and provide a few hours of respite to seniors. And also the use of community radio. A lot of our population listen to community radio, and so the message that we can provide through that. The other thing that we're also doing in some of the communities is what I call interactive community and nursing homes. So that back and forth of having seniors in the community come into the nursing home and have some personal care, like baiting, for example, as well as a social visit and a meal, but also go home with a meal or a few meals. And also the staff from the nursing home designated for Nursing Home Without Walls to be able to visit at home as well and provide some support to those seniors. And also, of course, that navigation or information piece is always there. There's also very much the supportive services, for example, foot care and some of the house maintenance and the social activities, and transportation is a big picture of this, a big component of what we do. Transportation to medical appointments, to groceries, to social outing. And in doing those components so far, we're also, you see on the bottom, we are really trying to encourage the local communities to become age-friendly communities as well. And I have to say, this is very much so the work of the coordinators in each site, but also the rural communities coming together for their aging population. This would not be, we were actually having a discussion last night about how we think it's really a rural culture of people coming in and saying, yeah, we can work together and we can make this happen. And it's a true community spirit, I have to say. Some of our participants, just quickly, thus far, as we are still very much active in this project. So what you're seeing there represents just about 335 participants right now in our 4 communities here in New Brunswick. 40% are in their 80s, 62% female. We see that high level of no post-secondary education. But look at the income. Half have a 25,000 or less household income. And look at our Prisma 7 score as well. So most of our participants, 40% have a score of 4 or more, and 25% have a score of 3. What does that mean? The Prisma scale is a scale of 1 to 7. If you score a 3, you're considered sort of targeted to possible frailty if you move on. Score of 4 or more is you should be assessed, and there's high risk for frailty. And so we are capturing the ones that we hope through Nursing Home Without Walls, and our data is starting to show that we are actually catching them at that right moment. And they all fall in what I call that gray zone of they don't necessarily qualify for certain services that they would benefit from aging in place, but they are also in need of services. And so what it seems is that we are actually responding to or capturing that gray zone of where they don't qualify. Very preliminary. I didn't want to start with graphs and whatnot. This is so ongoing. So we have time 1 and time 2 data that has been collected. Time 3 is currently being done as well. And my wonderful summer students are going to do interviews this summer as well to wrap up sort of that evaluation piece. But we are seeing some very interesting preliminary findings that I will highlight. And again, they are preliminary, so but we are hearing through our surveys that 60% of our participants did not present themselves to emerge for a non-emerge situation or crisis, or because they knew that they could reach out to Nursing Home Without Walls, or they knew that they could get the information elsewhere and not necessarily go to ER. We're also having a very high level of satisfaction from not only our participants, but also the families that are contacting us about the difference that they're seeing in their mother or their father, the impact that it's having, and also a decreased feeling of loneliness or isolation, increased knowledge on how to remain healthy and how to access certain services, and also an increased feeling of security in their home, but also in their community. And again, it's addressing the gaps. It's addressing that gray zone that I call of access to services and social health. And so to wrap up, I love this quote. It's from the Port Elgin site, if I'm not mistaken. And it's Nursing Home Without Wall sees the possibilities when seniors only see the barriers. And so when they think there's no solution and we can help them out and connect them to what it is that they need, we really see the difference and the impact. And so we believe it's an innovative economical model based in long-term care facilities. And again, we think that's the success. Long-term care facilities in many communities can really be a hub on aging. They are respected, people volunteer there. We fundraise for long-term care facilities. And so there is already that sort of respect and momentum that's happening there. Nursing Home Without Walls is definitely a flexible model, and to keep to its success, it has to remain flexible, but it also has to remain very community-based. And age-friendly communities really is sort of a central part of this as well, of the communities coming together. And again, that high satisfaction and positive impact. So I'd just like to take a few, the last few minutes to thank you to the team. Again, this would definitely not be happening without them. All of them are here except Patricia and Bruno. So Andréane Blanchard, Darlene Olton, Teresa Salmon, Sylvette Savoie, Gaëtan Haché, Guylaine Ward, Audrey Savoie, and the two students that are currently in the project. There have been others, Alison Haché-Chiasson and Mathilde Thériault. Couldn't do this without you. And honestly, if you have questions, please go to our booth. They are the expert in this. They are the ones who are in the communities and doing the wonderful work that I just spoke about. Thank you so much.
Jennifer? Are you Jennifer? Oh, good. Okay, Jennifer.
Put this on a short person setting. All right, good afternoon, everybody. My name is Jennifer Peterson, and I'm the research coordinator for the Fresh Care Project. And FRESH stands for Frailty-Focused Enhancements to Seniors Hospital Care. So the principal investigator for this project is Dr. Pat Feltmate, who's a geriatrician based here in Fredericton. He's also the medical director of Collaborative Care Seniors Health at Horizon Health. And the co-principal investigators are Danny Jardine, who is the Regional Director of Collaborative Care Seniors Health, and Carla Feig, who is the Research Manager of Collaborative Care Seniors Health. So emerging research suggests that being in hospital can lead to an increase in frailty, and it's often the result of either a lack of mobility or due to the effects of potentially inappropriate medications. So by emphasizing the 5 M's of geriatric care framework, this project is looking to identify and address this rise in frailty identified in acute care hospital settings. So older adults in acute care benefit when their healthcare providers have specialized knowledge and skills. So our project is investigating the impact of providing really targeted education to nursing staff on the latest best practices in geriatric care. So frailty, we've heard a lot about frailty today. It's certainly a growing problem in Canada. In 2020, 1.6 million Canadians were living with frailty, which is about 1 in every 4 adults over the age of 65. But in reality, the number is probably larger because a lot of the times frailty goes unreported or undetected. By 2030, the number of Canadians living with frailty is expected to increase to about 2.5 million. And of course, with that increase in frailty, you get a dramatic increase in the requirement of caregivers. And the number of caregivers is expected to double between 2020 and 2040. So really overall, the effects of frailty and that burden of frailty in Canada is steadily growing. And by no surprise, in New Brunswick, frailty rates are even higher here. So in 2019, about 19.5% of New Brunswickers were 65 and over. That number, of course, is expected to rise to over 30% by the year 2036, which of course is then higher than the national average or the national expected rate of about 24%. So additionally, between 2017 and 2019, about 36% of New Brunswick's older adults were hospitalized. And of those folks, 20% were frail, which is more than 11,500 people. So we've heard a lot, in the media over the last few years that New Brunswick really has an aging population, but that also means that New Brunswick is becoming frail faster than the rest of Canada. So collaborative care seniors health at Horizon recognized opportunities to improve the care experience of older adults while they're in hospital. The project was created to improve outcomes for older adults in acute care by working alongside the staff and providing education and training on the best practices in geriatric care. So we have research nurses and research assistants currently working closely with nursing staff on selected hospital units to provide them with educational resources and coaching and to encourage them to implement that new knowledge. So originally, 7 family medicine units were selected across Horizon facilities. They were selected as our study sites. The list of locations is up there on the slide. We did, however, have to remove Sackville for data collection, but we're going to continue through with the education component to that facility at the end of our study period. But our study sample at each one of those sites includes both patients and staff. So for patients, we're recruiting those who are over the age of 65 and who are in hospital for an acute incident. For the staff, we're looking at really reaching out and providing the education and training to all of the nursing staff on all of the units that are in our study. So we're talking about RNs, LPNs, and PCAs. So during the planning phase of the project, we selected the study sites through a readiness assessment. We developed the data collection tools and developed the education materials. Currently, we're in the implementation phase, which is that little yellow dot up there on the screen. So right now we're collecting clinical information related to the presence and severity of frailty. So we're doing that at our study sites. And we're also just starting to present the education and training related to the 5 M's of geriatric care and frailty prevention. And we start that next week. Our first site to receive the education sessions is the Sussex Health Centre. In addition to that, we also have developed some really unique coaching services that are dedicated to key leaders in these hospital units. So charge nurses, resource nurses, nurse managers, because they're often the folks who are in charge of implementing and sustaining change on units. So we're providing some coaching in change management and other topics to the leadership in the units as well. So as of this week, we have started data collection on 5 of 6 units. The last facility we were able to get into this week finally was the Moncton Hospital, which was very exciting for us. So during the next phase, which is evaluation, we'll be analyzing the data that we're currently collecting, and we'll be conducting some focus groups and interviews. And then we have the sustainability phase where we then take our findings, share them, and focus on refining. And we have an education toolkit that we're going to leave behind when the project's over. So making sure that that's going to continue to meet the needs going forward. So as I just mentioned, we are in the implementation phase of data collection. So the patient data we're looking at includes mobility audits. So how often are folks up and moving on these family medicine units? We're looking at shift handover audits to see what kind of information is prioritized by the nursing staff. We're looking at chart reviews. So we're looking for things like medications, any potentially inappropriate medications. We're looking at incidents of falls and incidents of delirium. So the data collection is happening over 18 weeks. So we have a 6-week block of data collection that's ongoing right now. So that's our pre-intervention data. Then we have 6 weeks of data we're collecting while the education sessions are going on. And then we have 6 weeks of post-education data. So the education for staff, so what does that look like? Basically, we have 2 research nurses who will be providing those education sessions through a seminar type format. We have to be really flexible about how we present them on the units because of staffing and workflow and workload and all those things. So we have 2 research nurses doing that piece. They're going to focus really on frailty prevention and, like I mentioned, that 5 M's of geriatric care framework. So we've taken a lot of time and a lot of care to really highlight and focus on the key takeaways for best practice in geriatric care. And we've also developed a list or a group of resources that the nursing staff have currently available to them through Horizon. And again, just what do we have, how do we use it, and when is it appropriate to use? We've also created a really great case study that follows through each aspect of the 5 M's. So it provides an opportunity for, during these education sessions to collaborate and come up with ideas and talk about this, potential patient of ours and what are the red flags and what can we do about it. We've also created a really lovely set of posters, I think, and they have the key takeaways on them regarding each of those 5 M's of geriatric care. So we have 1 poster dedicated to frailty as a whole, and then 1 poster for each of those 5 M's. So 1 for mind, mobility, medication, matters most, and multi-complexity. And again, those will be sort of a supplemental resource for staff. We'll have them up in the units, and they'll be part of our education toolkit that we leave behind. All of these things will be available across Horizon and hopefully farther once we're done the project. And we do have all of those posters with us today. We're down in that back corner and we're giving away shoehorns if we haven't already made you take one with you. I said I'm not leaving here tonight with shoehorns, so I may be here tomorrow sitting in the corner, still handing out shoehorns. That'll be me. So during the education period, we're also asking staff to provide us with some information. So some demographic information and some information about their current level of knowledge on these geriatric 5 M's. And then we're going to ask them to do a class satisfaction survey at the end just to see how we can improve the program going forward. So as a Horizon Health initiative, the project has involved several levels of leadership within the organization. We do have a 15-member steering committee that has been fantastic, providing guidance and help with us along the way. So that committee is made up of, almost every aspect of Horizon. We have all the clinical areas, we have research services, pharmacy, physio, everybody's represented, which has been great. So they then take that information back to their respective areas and help us with supporting the implementation of best practices for geriatric care. We also have real engagement going on at the unit level. So we've had a readiness assessment to decide, what facilities and what sites and units were ready for something like this to come through. We're now working on those units. We have a lot of promotional material for them, posters, we're coming, we're here, here's who we are, branded clothing, all this kind of stuff to make us familiar and make it an easy win for us. So moving forward, we are really hoping to generate an increased awareness about the importance of frailty prevention and the importance of really actively incorporating the 5 M's of geriatric care framework into acute care settings by offering education and coaching to the staff on those areas of expertise. So we're kind of still in the beginning stages of this, but we anticipate that our findings will be shared publicly through a variety of means. Of course, they'll be shared among the Healthy Seniors Pilot Project Community of Practice, hopefully highlighted at another future HSPP project showcase. We would also like to publish our findings in an open access journal and present at future geriatric and aging conferences. And we intend to create a policy brief that we can bring our findings and ideas back to both the health authority and the provincial government. As you can imagine, we have experienced some impacts due to COVID. We've had, I don't know how many start dates for this project, but due to, the new wave, the next variant, the next wave, it's taken a long time to actually get into the hospitals, and you can understand that. But again, right now we are actively collecting data in 5 of 6 sites. I wasn't sure, there were moments I wasn't sure that was going to happen. But it makes sense, right? There've been increased protections in the hospitals, and again, we're just so happy to finally get in and to do some data collection. We also have had to make a lot of plans about what do we do in case there's an outbreak on a unit or an exposure. But again, we've worked through a million contingency plans, and things are rolling right along, and we're really thrilled about that. So that's my story, and I'm sticking to it. I do thank you so much for your time today. It was really lovely to be able to share our project. We've been looking forward to this opportunity, and again, really looking forward to sharing our findings in the coming months. And if you do have any questions or comments or want to see any of those posters or anything, or you really need a shoehorn, down in the back corner. Thanks, folks.
Good afternoon, everyone. My name is Ali McGill. I'm a PhD candidate at Memorial University in the Interdisciplinary Studies program. I'm going to be speaking to you today about a novel research methodology. I'm really happy to be able to have this opportunity as a student. I'm really humbled by all the different projects and research that's being done in New Brunswick and elsewhere in Atlantic Canada. So this is really inspiring, hearing from you all today and seeing all the work that you're doing. So the project that I'm going to be referencing, it recently used a research project to examine and analyze the hospital to home transition process in New Brunswick. And I'll be using this project as an example of how a FRAM, or the functional resonance analysis method, can be applied and potentially contribute to developing practice and policy recommendations that benefit the lives of older adults. I also want to take this opportunity to thank my research committee, Dr. Rose McCluskey from UNBSJ. My other research committee members are from Memorial University in the engineering department, Dr. Doug Smith and Dr. Brian Veitch. And I also have a research collaborative partner, Vahid Salehi, who's another PhD candidate and who's kind of stuck on doing the FRAM just like me. So he was supposed to join me today, but he wasn't able to make the trip from Newfoundland. So what do we know about hospital to home transitions? Well, terms used in the literature to describe the process include complex, error-prone, complicated, and risky. So what do we do when things are complicated or risky or error-prone? We tend to try and simplify them. And because of this tendency in healthcare, research in this examining hospital to home transitions are often fragmented. It investigates single dimensions of the process. It targets single professional groups with very little attention paid to system level issues. So research approaches to date are not really providing us with a comprehensive, systemic, or interdisciplinary understanding of this complex process. We are really only seeing the tip of the iceberg and using this knowledge to inform practice, policy, and system design. So when we think about navigating a hospital to home transition, even if the older adult is ready, physically able to be discharged from the hospital, the transition process can encounter several compromising issues. I've listed only a few here because there's many more, as many of you have told me in the corner about your experiences as caregivers, patients, or healthcare professionals who have tried to navigate the hospital to home transition process. The first one is costs. There's maybe recommendations on the inpatient unit about discharging a patient home or an older adult home, but when they get home, can they afford the recommended treatments? Can they access the recommended treatments? Do they have a family doctor or a nurse practitioner that they can go visit? And if that's the case, can they access them in a timely way? Also, are these professionals that are working in the community after a discharge communicating? We know we have 3 silos of care in the healthcare system in Canada. We have the acute care system, the primary healthcare system, and the community-based system. What we're learning through this research is that many of these healthcare professionals across these silos don't have an ability to communicate with one another. They each document in their own information technology systems that don't communicate with one another. So an older adult can be telling a story over and over and over again when this information actually exists and has been accessed and documented in many places already. Another thing is unpredictability of services. When you're discharged home from the hospital, do you know when your home care is going to start? Is it actually going to arrive? Is the schedule going to work for you as an older adult? Are your family members able to be there to help with the process? Do you live in a rural area where the services can even be put in place? So there's lots of things we don't know. So ideally, the process of a hospital home transition should be a longitudinal connected process. But in fact, it's more of a collection of episodic clinical encounters where the older adult and their family are often the lone point of consistency in the process. As professionals, and I'm a healthcare professional, I'm a nurse practitioner. I've been in nursing for 20 years for Horizon Health Network. And I know my system very well, my own system, but do I know the systems of systems that exist that an older adult has to traverse in order to access care? We don't know the territory as healthcare professionals, we know our own. We don't know the territory older adults have to navigate, and we don't know the routes older adults take through the system. So right now, a hospital to home transition is often a journey without a map over treacherous territory. And we need a new approach, better understand this complex process, provide recommendations for policy and practice that better match the realities of actually what goes on in healthcare and how care is experienced by older adults and their family. So hopefully that was the setup, and here's the delivery, and I'm hoping it goes well. This is a new research methodology that has been, that was developed in systems engineering, and it's had great success in examining and analyzing complex healthcare processes and other types of domains such as maritime transport, aviation, nuclear operations. The FRAM, or the Functional Resonance Analysis Method, is a mapping approach. So we're looking at creating a map that produces a model of the everyday activities, interdependencies, and variabilities within a process or system. From this, valuable insights into how a complex process actually occurs can be appreciated. Qualitative methods such as document reviews, observations, as well as interviews and focus groups with frontline workers and patients and their families are used to inform the mapping process and building the FRAM model. So this is a little crash course on what the FRAM is. I'll try to do this really quickly, and I hope you understand. But this is a function, and a function is a work activity. And we use these functions when we develop a FRAM model, and we plot them all together, and they're connected by what we call aspects. And I've listed here 6 aspects. So when we think of a function or activity, it could be taking blood, or conducting a family meeting in the hospital, or transferring the patient for diagnostic imaging. So we think of that as a work function. But in order to connect the work functions within a system, we need to describe them in terms of their aspects. So when we conduct a FRAM interview or a focus group, we go through and we ask the experts of the system, the frontline workers or the patients and their family, well, how does this function start? And that's the input. What's the output of the function? So what emerges from the function? What's the precondition? Like, precondition is what needs to be satisfied before the function or work activity can actually be started. What are the resources or materials or people are needed in order for this function to take place? How is it controlled? Are there procedures and policies or guidelines that control the process? And what about the time? How long does it take? Okay, what are the temporal constraints that exist? So after identifying the functions and their aspects in a healthcare process or a system, it's determined how are they connected and how do they influence one another. So this is the FRAM model of the hospital home transition process in New Brunswick. So as you can see here, it's pretty complex. Yeah, it's really complex, but this is what we want to do. We can't simplify this. We have to have an approach that acknowledges the complexity of the process and lets us know what actually goes on in the workplace and how care is experienced. And the next thing that we do with the FRAM is there's a dynamic version of the FRAM called DynaFRAM. And what that does is it looks at the outputs of each function. So what happens when a function happens and how quickly does it happen or how slowly does it happen? And what we're able to do is monitor an individual patient's journey through the process. So if I was doing this myself, I'd click and you'd actually be able to see in real time a journey, a patient's journey through the system. Well, maybe it'll work. So this is an individual patient's journey through the system using DynaFRAM, knowing the time it takes and the different functions of the work process that are active. So what can we learn when we look at a complex process using a functional lens? We can learn about the different functions in the process, how they are interdependent, and the variability that emerges in the process. And what that can do is inform our policy and practice much better than just looking at single dimensions or looking at it through just one disciplinary lens. So as a take-home message, FRAM is a mapping approach that can produce a functional model of a complex healthcare process or system. DynaFRAM is a customized version of the FRAM that's able to monitor an older adult's transition from hospital to home. And a combination of FRAM and DynaFRAM can help identify the challenges of the transition process to better inform decision makers. And that's what was used in this study. They monitored older adults through the transitions process in 3 different communities in New Brunswick, and they were able to look at their individual patient journeys. And that information is able to inform us better in terms of system design, policy, and practice recommendations. So for me, as a PhD candidate, I saw the results of this study, really interested me. And what I learned from it is that healthcare professionals in the hospital worry about what happens to a patient or an older adult when they go home. How is this care going to be provided at home? How is this going to happen? And what I hope to do with FRAM and DynaFRAM is to map, I'm based out of Memorial University, so I'm going to be mapping and modeling the comprehensive geriatric assessment process in St. John's using FRAM and DynaFRAM. So I'm going to be following older adults in their journey in the community before they even have to go to the hospital and trying to see how we can improve that process and improve the lives of older adults. So thank you very much for this opportunity. Okay.
All right, hello, how's everybody doing? I know, information overload. Our brains feel like they're swelling and we're trying to absorb as much as we can. So much good stuff happening. So quick introduction, my name is Vicki Muscat. I work for Xenex. I'm just about a year old with the organization, very proud to be a part of the group. Today I'm going to have a quick chat with you about the Insights Lab and how it came to be. So on the agenda today, I'm going to give you a brief overview of Xenex in case there's someone in the room who doesn't know who we are, as well as telling you what the vision is of the organization, what's kept them running for so long, as well as the thought behind how they were going to use data in order to generate insights to improve care. And also the people that we had to collaborate with along the way. As you can well imagine, long-term care providers probably aren't initially set up to run an analytics lab. So that took a little bit of legwork, if you will. So a little bit about Xenex. They are a long-term care provider. Since 1988, so almost 3 decades, they've been family owned and operated. And they've offered a variety of retirement living options for seniors that spans about 40 locations. And that has a mixture of long-term care homes and retirement living. And we service about 4,500 residents each and every single day. In order to be a Xenex employee, everybody needs to follow this vision. And I can believe this wholeheartedly, having been there for a year. This is what everybody operates with. We all strive for one important goal, and that's to improve the life of each and every resident living with us. So we want to lead the way to better care. One of the ways that Shenex does this is by continuously improving and innovating. Not that long ago, they decided to test this new tool called an inside positioning call bell system with a company called Tenera. This device is like a call bell anywhere. So if you can imagine a long-term care home, normally you have a button, you press the button, someone comes to help you. This device is on your bracelet, kind of like a Fitbit, a little red button in the middle. Or it can be a pendant. This way, if the resident is in the washroom, down the hall, in the dining area, and they need help, they can get it. In addition to that, there is a second feature to it where the nurses could actually impose rules to the devices. So if a resident was at risk of elopement, they could get notified when that resident was too close to an exit. If a resident was at risk of falling, they could get a notification if they got up in the middle of the night. So additional safety features. But what they came to realize after a while was like, hey, you know, all of this information is being collected each and every second of the day. Because in order for all of these rules to work, there had to be a geonavigational system in the back end tracking everything every second of the day. So they thought to themselves, well, how can we actually leverage this data in order to improve quality care? Surely there has to be something. Hence, the Insights Lab was born. So if you think about how care planning typically runs today, you have a resident who comes in, there is a very comprehensive 72-hour observational assessment that's done by the INRI long-term care assessment form. This is an international best standards tool that has been used for quite some time. So a multidisciplinary team will take all of that detailed information, develop an action plan in order to carry on and improve the life of that resident. But what if we added another layer to that? Because what we do know is that the resident is getting that detailed attention 4 times a year, and care plans may get amended if a significant event occurs. What if no one's around to see it? That's where we become the eyes where the eyes can't be present. We can take all of that rich data and be able to feed it back to our care providers in a meaningful way so that they can actually work on a more proactive and predictive mindset as opposed to reactive, when something might have been too late, where had we known in advance, could have been averted. And of course, the Insights Lab is where all of this magic is expected to happen, and we are in progress of that. So as you can see, there's a whole host of data that we could be leveraging right now, from not just the bracelet, from the inside positioning call bell system, but also the long-term care assessment forms, our electronic health records, our medical records, all of this information so that we can get the most holistic, individualistic view of every single resident every second of the day. And we can sift through the noise and give the information to care team members in a timely manner, in a way that they need it, that's meaningful to them, because we all know that data is just data unless it means something to you. So that is our goal. So just to give you a little bit of a perspective of how this would work, for instance, maybe you have a resident who comes into a home and she needs to be walking more to increase her muscle strength, durability, stability. We're able to provide that insight in window as to whether or not that's actually taking place. And if there's a risk of decline, which would lead to a risk of falling, we can then alert the care team to say, hey, you know, you may want to go and check on Jane. Jane is actually decreasing her walking cadence significantly. She's fallen before, maybe something's up. At that point, they can take that moment to intervene and see if there's anything wrong. And maybe they can right the ship and avert a potentially aversive situation, therefore leading to a happier Jane. So in order to get up off the ground, you know, one might think, well, you know, I've been here for a year. Why didn't I solve all the world's mysteries? Well, in order to actually get to where we are today, we did have to break down some barriers. As you can imagine, developing a large repository of meaningful data was no small feat. We had to partner with our company, Tenera Care, or the provider for the inside positioning call bell system. in order to get access to our data. In turn, we also worked with Google Cloud and Python Analytics to provide a smooth transition from the data from Tenera in order to our own cloud storage in a secure fashion. From there, we are going to need to clean the data and be able to start mining it, develop machine learning, and all of those magical, wonderful things that will yield those positive outcomes that we're hoping for. Alongside, we're also partnering with academic institutions like Dalhousie University. We recently did a hackathon. Some of you may have seen it on social media. It was really exciting. There was a pool of really young, bright minds who came online and worked together to solve some challenge statements over 72 hours. And let me tell you, the ideas that came out of that crowd was pretty impressive, and we actually plan on implementing some of them. We also work very closely with MyTax, who is an enabler of existing students or recent graduates to help them get that real world experience. We are on our 4th application right now, and currently with me today is one of the MyTax recipients. She's a data engineer, and she's been instrumental to the team. So it hasn't been a small feat, and it's been an incredible journey. And I do hope that if I ever come back to talk here, I'll be able to share some of the more exciting findings that we've been able to garner along the way once we get everything up and running. And if you have any questions and you're curious about what we're doing in greater detail, I do encourage you to come see us. Just right around the corner to the far right, we have some really snazzy masks left, super cozy, in case you're looking for one. Otherwise, have yourselves a wonderful rest of the day, and thank you for your time.
Good afternoon, everyone. My name is Alicia Gadet. I'm from the Department of Social Development. I'm very happy to be here today to talk to you about a project that is just getting underway. It's the Strengthening a Palliative Approach in Long-Term Care Alliance. They're scaling up a palliative program in long-term care. With me today, I have Dr. Durepeau and earlier Dr. Rose McCluskey from the University of New Brunswick, who are partners in this project. With the University of New Brunswick. And I'd just like to thank Dr. Kelly and Dr. Castellainen, who are leads in this project. They are from Ontario. Dr. Castellainen is from McMaster University. And they started this work about 13 years ago when actually I was a master's student at Lakehead University. Through the Quality Palliative Care in Long-Term Care Alliance, where we were looking at improving quality of care at the end of life for individuals living in long-term care. And this has grown into this Supporting a Palliative Approach in Long-Term Care Alliance that it is today. And why it's important that we support palliative approach in long-term care is that 25% of deaths in Canada occur in a long-term care home. So it's really important that we have a formalized program in these facilities to ensure that there is a good death for residents and that the support is in place for staff and family members to support that. Current barriers that exist is that staff and family members have a discomfort around death and dying in any time, but especially even in a nursing home. There's uncertainty about how you initiate those conversations, when it's appropriate, how you do it, whose role it is, and what do you say. So having tools in place that can support that with staff and family members are important to do that. Research from this project, that's from earlier research, has demonstrated that through having a formalized palliative program, it increases family satisfaction. It will decrease hospitalization or trips to the emergency department by 55% in the last year of life of an individual in a long-term care home. And it also increases the likelihood of an individual's goals of care being met. So what is a palliative approach to care? Palliative approach to care is for residents who have a condition that has no cure. It is for focusing the goals of care to improve quality of life. It shifts the focus away from prolonging life, but understanding what does that quality of life mean for an individual. It is an active approach to care. So it's about being dynamic and changing the goals of care along with the residents' needs as their illness progresses. It's part of usual care. It's not about creating a specialty. It's about embedding this approach into the care in a nursing home or a long-term care facility. And it doesn't require a referral. So you don't need to wait for a specialist or for your doctor to initiate this. You can initiate this at any time in the illness trajectory with a resident. In order to implement a palliative approach, the Alliance developed this framework. So there's 4 pillars in the framework. Focuses on preparedness, symptom management, caring relationships, and organizational capacity. So many of the resources and tools and education they developed fit under these 4 pillars. So under preparedness, it's about those early conversations and helping healthcare decisions have the tools to make healthcare providers have the tools to make decisions, and also helping people understand the illness trajectory for different chronic illnesses. Identifying symptoms to understand when there is a change in condition of a resident, so assessment tools to support that. Education for the whole care team around symptom management, as well as educational videos for families and for residents. Nurturing those caring relationships. So having those care conferences so that you can have the forum to have those discussions around goals of care and to share when you're seeing that there's changes in a resident, as well as having that opportunity for good bereavement care. So at the end, having those conversations post-mortem with their family. For an organization, what are those things that you need to do as leaders in your organization to embed this approach into your organization? How do you assess what you have available to you that already will support good practices at the end of life? How do you encourage those external resources to support your philosophy of care? And how do you develop your champion, your team? So all those resources are available and are going to continue to be developed over time. So through the support of Health Canada, the SPA Alliance has been given a 5 years worth of funding to do knowledge mobilization. So what that means is they're looking to curate resources and adapt and disseminate resources that will support the implementation of a palliative approach in long-term care across Canada. So there will be an online national repository of resources that will be available, and we're going to be actively looking to try and increase the capacity of long-term care facilities in the country to start formalizing their programs in their homes. The objective of this project, there's 5 objectives, and I'll go through them in more detail. But the first is to build capacity to implement a palliative project, a palliative approach in long-term care, develop tools to support frontline staff to manage difficult situations, develop tools and approaches to support residents and families, build a national community of practice, as well as build healthcare provider students knowledge about a palliative approach. So with the first objective, building capacity, this is about leveraging existing partnerships and resources that are available that have resources that they've developed and promoting those. So some of the big partners, of course, are the Canadian Hospice Palliative Care Association, Virtual Hospice, and Pallium Canada. So these partners have a wide variety of tools already available. So promoting those and using those partners to promote the resources and the goals of the Alliance. How do we build capacity within the facilities? So there are some palliative e-learning modules that have been developed. And the one that's shown here, there's 8 different modules that your staff can go through. And it supports those 4 pillars that I talked about earlier. So how do you build a palliative approach to resident care? communication with residents and family members and staff, understanding what advanced care planning is, the goals of care, recognizing changes in mood, ability, thinking, and behavior, recognizing pain, suffering, and common symptoms of advanced illness, providing daily comfort and quality of life, supporting final days and hours of care, supporting loss and grief of residents, families, staff, and yourself. So these are available online, so you can do them at any point with you can encourage your staff to access those and be more self-led in their learning. With the second objective, develop tools to support frontline staff to manage difficult situations. There's many resources that have been developed that are being adapted for long-term care. So, and the goal of this project is to continue to identify more resources and customize them. Time goes by really fast, I realize. Develop tools and approaches to support residents and families. So we have many of these brochures currently at the table, and we invite you to come and pick them up. They're available in both English and French. And they talk about the different chronic illnesses that individuals in long-term care may be living with and how to have those conversations with end of life in relation to those chronic illnesses. Build a community of practice. So in partnership through the SPA Alliance and the Canadian Hospice Palliative Care Association of Canada, we're working to build a community of practice for professionals, patients, and residents to act as a professional resource on advanced care planning and palliative approach for long-term care, share tools and resources, and is also a safe space to discuss, learn, and explore. So we invite all of you to go to the website and join that community of practice. And the final objective, I'll invite Dr. Durapo to come up and discuss.
Thank you. My name is Pam Durapo, and yeah, I'll just briefly speak to you about some of the resources that we've developed as part of the SPA LTC program that are specifically to provide education for healthcare workers at all levels and students with a focus on long-term care, but they're really applicable to all settings where we're caring for seniors that may or may not be getting close to end of life. So one of the, I'm a little afraid to use this. Okay, good. So one of the new things that we've just developed that's not on the website yet is a virtual simulation. They call them simulation games. It is for healthcare workers to practice and students to practice making decisions around communication during end of life. So it was filmed in French and English in the simulation lab at UNB St. John. We had an amazing actress, Jeanette, you can see her there. And it provides students and healthcare workers with an opportunity to answer 6 questions about how you respond to those difficult questions that family members are asking and want to know about that. You know, as uncomfortable as it makes a family member, staff and students often feel unprepared and uncomfortable answering those questions as well. So all of these resources are going to be available on the SPA LTC website. And as Alicia mentioned, we have flyers about the different illness trajectories at our booth. So please stop by there. And the website is spaltc.ca. So thank you very much.
I'm at the age where I'm not sure if I need my glasses or don't need my glasses. I'm going to test it. Need the glasses. So good afternoon, everyone. My name is Donna Miller-Wallace, and I'm the Executive Director of Victoria Glen Manor. So today what we're going to start out by talking about is an overview of my nursing home, which is Victoria Glen Manor. We'll talk about the impetus for change in our nursing home over the last couple of years. We'll talk about the Waltons and our Kindness Ambassador, which is 2 programs that we implemented in the last few years. And we'll talk about a summary of key outcomes and some critical success factors. Hey, it works. So Victoria Glen Manor is a nonprofit nursing home in Perth, Andover, New Brunswick, about an hour and a half north of here. We have about 95 staff and we have 60 residents. And we are governed by a nonprofit, by a board of directors who are volunteers from our community. So we have noticed in the last few years that we're seeing more and more cases of dementia and Alzheimer's disease within our nursing home residents. Of course, we're not able to influence whether or not our residents get Alzheimer's or dementia, but we began thinking about how we can actually influence the culture and the environment in our nursing home when there is an increase in these significant diseases. So training our staff has always been of utmost importance, #1 priority in my mind, as far as dealing with these conditions. But we decided a couple of years ago to start and dig a little bit deeper into these conditions. So the most common behaviors that we see in Alzheimer's and dementia are those listed in the yellow. So the yellow behaviors, they're typically not dangerous behaviors, but they can be indicators of a progression of the disease to a point where potential dangerous behaviors does exist, such as falls, which can obviously, breaking hips is something that's quite common in elderly folks, physical aggression, elopement, or leaving the building unsupervised, or injury to themselves or other people in nursing home. And also the behaviors in the yellow can actually trigger other people in the nursing home to potentially get agitated or upset because they don't necessarily understand what's happening in the person that lives in the room next to them. So they don't understand dementia, and that can result in anxiety and frustration and anger. And one of the things that can happen frequently in a nursing home with somebody in dementia is that they wander from room to room or in the hallways, and wandering in itself is no big deal, right? Going for a walk. But as soon as somebody starts wandering into other residents' rooms, all of a sudden those nursing home residents can feel a lack of privacy. So sometimes also a resident can repetitively say a phrase or a word like, I want to go home, I want to go home, just like I say at about 4 o'clock every day at work. But maybe it starts at 3. Anyway, so, but really what's going on inside of them, we're not sure, but it's probably just trying to make sense on what's going on around them. So when we looked at those behaviors and we started to think about the resident experience and some potential goals that we could have for ourselves, we looked at the resident experience from the perspective of people often feeling socially isolated once they come into the nursing home. They're no longer with their family and friends, no longer in their family home. And it takes a bit of time to adjust to their new surroundings. And that time can be different for every single person. And it also takes a long time for staff, of course, to get to know the resident's habits, their likes, their dislikes, and so on. And even over time, those things can change. So my nursing staff, they're fabulous. And they try to fill social voids that the residents feel in their new home, but that is absolutely impossible with the funding that we get. And under no circumstance do I ever expect to have one-on-one care for our nursing home residents. So we needed to figure out how to address this lack of engagement that might happen, this slight confusion and social isolation. I added an extra syllable. So the programs I'm about to describe to you, we implemented those with the belief that we could potentially impact the residents' lives, their cognitive functions in the nursing home that they experience, potentially reduce the number of aggressive behaviors that we see in the residents towards others, and potentially even reduce the number of falls. So you may remember, like I do, being a little girl and watching the Waltons. Well, the Waltons was an American TV show. Everybody knows the Waltons, please say yes. Okay, yes. So it was taking place in Virginia. It was in the Great Depression and World War II. And that was exactly the time that most of our nursing home residents were growing up. And when the TV show was on from 1972 to 81, that's the time they were raising children like me. So my parents and I used to watch the TV show together. They could relate to it from a slightly different perspective than me. But this was one of the most popular TV shows on TV back in the 70s and early 80s. And even now you can watch reruns almost every night. So if you think about what the Waltons TV show represented, you would think about family, family values, you think about safety, acceptance, togetherness, gatherings, and one of the most important things is love. And that family showed love, not just to the people in their family, but also to the other people, their neighbors and their friends and other people outside their family group. I really do want to go backwards one. Okay, forward one. Okay, thanks. So in an attempt to mimic the sense of family in our nursing home, we found our own Waltons, and they are literally named the Waltons. That is their last name. And I'm very fortunate that our director of nursing, her birth name was also Walton. And so I do attribute this program to her and her ingenuity and kind nature. So thank you, Erica, for everything you've done. So Jim and Doreen Walton joined our nursing home family in August of 2019. And Jimmy, as he's fondly known by our residents, is over at our booth. And he is a humorous tease. He tortures people near to death and everybody loves it. He's a very good snack maker. He can meet residents where they're at. If they want to talk about farming potatoes, he can talk about that. You want to talk about splitting wood, he can talk about that. You want to talk about crafts, oh, maybe you should talk to Doreen, his wife. But one of the things that they do over and over and over and over and over is they provide empathy, love, and care to the residents. So during the 4 p.m. to 7 p.m. time frame each day, many of our residents with dementia experience sundowning. So during this time, residents have a tendency to be unsettled. They want to go home. They sometimes are just generally agitated. And as a result of that, we decided to have the Waltons come in our nursing home from 4 until 7 in the evening as a way to distract residents, engage them, and allow our nursing team to get others ready for bed and help them settle in for the evening. So anywhere between 5 and 24 residents will gather in our spacious activity room every evening. And what they do, they could be snacking, they could be painting. Did I mention snacking? Yes, they could be creating crafts, and some of those are at our booth on the side. And what they do is they create these things and feel a sense of creativity and being a part of something. And what the Waltons do is they actually look at what each resident needs that particular day, that particular time, and they address that particular need. And so many of our many pieces of artwork that our residents have created, they have ended up selling these on online auctions and giving them to friends and families for Christmas presents, birthday presents, and so on. So what's happened is this group of people, 60 residents who didn't really mean to live with these other 59 people, they show up in our nursing home, and all of a sudden we're trying to create a family. And that's what their jobs are. And I'm very thankful that our Victoria Glen Manor Foundation is the funder of the Waltons, who began in 2019. I also want to touch on the Kindness Ambassador Program, which is also funded by our Victoria Glen Manor Foundation. So in 2020, we were able to create this role called the Kindness Ambassador. And we're very fortunate to find Tara Sear to fulfill this role. And she's from our community of Perth Andover. She's an independent contractor, and she assesses which residents need kindness, companionship, one-on-one activities that are unique to them in that particular moment. So she has been known to sit down with residents who are receiving palliative care and hold their hands, comfort someone who's just not feeling well that day, perhaps just chatting and again, meeting them where they're at. We count on her judgment, her people skills, and her kindness in order to find the ways that she can be most beneficial to the residents and treat them as the VIPs, the very important people that they are. And we end up receiving many, many compliments on Tara's performance. One of the residents said, "Your best employee is Tara." And I'm like, she's not even an employee, but thank you. But this is what we hired Tara to do, to be kind. So speaking about the key outcomes. So I wanted to talk about key outcomes. And due to COVID, we have a little bit of a problem coming up with quantitative results. We can't necessarily display that we have a reduction in aggression or falls. But one thing that the residents are very proud of that some of them wanted me to mention is that they did raise over $2,100 themselves on the crafts and things that they created for the nursing home, and they reuse that money in order to buy new crafting supplies and so on. But there are a lot of qualitative results of these programs, and I could go on and on and on, but I'm not allowed to do that today. But so, for example, around the cognitive functions, we had one lady who, like I said, repetitive phrases. Her repetitive phrase was, "Can you tell me something? Can you tell me something? Can you tell me something?" And after spending time with the Waltons, she was able to have a conversation about her childhood, about her career, about her family, and so on. Many residents will receive emotional support and comfort from the Waltons. There was a lady who recently lost a loved one, and Doreen was able to sit down, talk to her, and mourn with her, right, as nobody else really could. So there have also been many instances of residents who haven't been eating properly at their regular meal times for whatever reason. And yet once they sit down with Jimmy and Doreen, they have snacks, they definitely get their calories. And some of them are actually healthy calories. So the programs that we have created, it actually ends up being, there's a sense of community, right? And that's what we're really looking for from the Waltons and Tara, is that there is ongoing support and love and caring for our residents in a way that our regular staff are not really paid to do and really don't have necessarily enough time to do. So when we look at our critical success factors, just touching on a couple of these things, we are very fortunate to have donations from the Victoria Glen Manor Foundation, and that really does come from the community and people who care for the residents who live in our nursing home. 100% of the donations made to the foundation is used for our residents. And also we needed to find people, special people, to fill the role of the Waltons and the kindness ambassador. So we needed to have self-sufficient, kind, gentle, and accepting people. So I do want to thank you on behalf of everybody at Victoria Glen Manor, the residents, the staff, my board of directors, and everybody who has helped me put this presentation together and who lives in the nursing home day to day or works in the nursing home. I want to thank you for your time.
Hello, it's loud. I'm here today to represent the Salvation Army Gardens. We put those in, of course, with funding from the Healthy Seniors Pilot Project. And I have with me some dried tomatoes that were ground up, so powder from the garden, carrot tops that they dried and ground up. And of course, we teach them how to save seeds. So I'm just going to go through this a little bit. The title of this is Garden Growth. I teach a lot about the therapy gardens and of course, what being in the garden can do. And so it's not just about the garden growing itself, but of course, there's a real energy that actually can be measured between soil and people. And so that's something that we think is really important. But of course, we couldn't have done this without the funding from the Healthy Seniors Pilot Project. And I do represent the Salvation Army with this proposal, and Natural Capital is a business that works with us. So when I asked, about seniors being in the garden and how important it was to them, we know that, we all know that most of the seniors actually have a history of being on farms or having their own gardens, especially if they're post-World War II or during World War II. And so it's interesting to talk to them. Before this project, I put in another garden and I was told I had to put in potatoes or it was not a garden. And so I listened very carefully to what seniors have to say. But so the funding was to create a garden space. It was completely accessible. So for seniors who are in wheelchairs or mobility impaired, and the seniors are invited to be participants, but everybody is invited in the garden because we wanted it, of course, to be intergenerational and multicultural and to bring in people. We've had nursing students come over, children from daycares, and that just makes, of course, the garden more exciting. And these are just pictures of people who have been in the gardens and in the workshops. The research, of course, went through the St. Thomas Ethics Review Board, and all of these participants have given their participants and non-participants, just visitors, have given permission to use their pictures and their names. And some participants insisted that we use their pictures and their names. They were very proud of what they did. I have over here on the table a tray I brought in. There's only 32 cells in it, but there's 194 seedlings. So sometimes we get a little off track, but they're enjoying themselves and they make sure they don't miss a workshop, and the workshops correspond with what we're doing in the garden. So it's a good teaching environment and they have lots of fun. So these are just some pictures of what they do there. I think I might have gone back one. So when we began this project, you can see on the top, the garden is about 50 by 80. And this was the first year, so you'll only see 4 raised beds. Right now we have 12. And we were told last year that we really need more. We also need more shade in the garden. So you can see how hot that would be to work in. And so, of course, I talk about seniors as though I'm not one, but it is hot, and anyone who is older, an older senior, they find it very hot in the garden. So we're still working on what they're doing, but in the bottom, you can see that we've added more raised beds, and we want to do everything we can. So we have put in a wheelchair ramp, the raised beds, the shade, we have a raised area where they can wash the vegetables when they want. There's washrooms, of course, in the Salvation Army building that's right there. And what we wanted to do with this is not just create the garden was really important, but we wanted to be able to give really solid results of what those are. There is a lot of literature. It's not like I'm adding anything new, I'm just kind of adding to it, especially with New Brunswick. So I use a political economy framework, and it's really a case study, mixed methods. Quantitative is about measuring food, counting numbers, who comes, who doesn't come. This year we will start adding up the cost of that food, because I think that's more significant than the number of pounds that we actually harvest. So we did begin, of course, like everybody else, in pre-COVID. We wrote our proposals, and post-COVID, we got to try to figure it all out. We have extended this into the 3rd year. As you all know, that there's not the additional funding to go into that 3rd year. So we're really being creative and scrambling, and we're so fortunate, like so many of you, to get intern students from the universities that are close by, and to have people who just want to be there and want to volunteer and help. As soon as a lot of people find out that we have the workshops, they'll just say, "Oh, can I come and do a workshop?" And I'm like, "Oh, yes." Last year, a girl came in and she did dyeing fabric with the vegetables, and it was just so cool, and they loved it, and everybody, it was something different. What we have done, although the main garden, that 50 by 80 that you saw, was funded by the Healthy Seniors Pilot Project, we were also able to last year add on to that, which is in the process of becoming an edible forest therapy garden, and it will be all fruit, herbs, and flowers. So we'll have the vegetables, herbs, and flowers in the main garden, and then we will have the fruit in the other garden, and it will be more tactile and really geared for kind of that therapy space. So we're just really happy that we've been able to get this far, even during this COVID period. It is in Fredericton here on St. Mary's Street. It's behind the Salvation Army Community Center, the food bank. So the food bank is attached to is right in that building. And of course, during COVID, or the worst year of COVID, when everything was in lockdown and we didn't really know what it was, we were able to take all of that food right into the food bank. So Hayes Farm, we partner with them a lot, and we go back and forth with them, and they have extra food they give to us. We have food we give to them, and then we take it various places, and we still make sure seniors get it. We all know, and people have talked earlier about food insecurity. It's not a secret. We know that the food bank uses are escalating. They're going crazy. In 2019, the food bank in Fredericton, at just the Salvation Army, gave out 1,500 pounds of food a month. In 2015, there was by 2015, there was a 35% jump in just seniors using the food banks. Generally, they did not. And then in 2019, another 10%, and then in 2020, another 20%. And those are seniors who are finding that they have to use the food bank. And since CBC just reported 3 days ago that oil is going up 70%, I'm thinking, where are they going to get it? They don't have 70%. So really, if we can provide food, at least that they can get all summer and process for the winter, then we think we're doing at least something good. And of course, many people have presented on isolation, and when they get together for the workshops or in the garden, it is just so cool. It's just so much fun to watch, and they tell their stories. And there's a picture over on my desk in a flyer of a gentleman who's in a walker, and he's the one who said you can't have a garden without potatoes. And so I called the soil guy, he brought it. And so Edwin went out, and he would go with his walker, and he'd move his walker and shovel a little bit and move it some more and shovel a little bit. And what I found in the garden at the Salvation Army was people who are mobility impaired, if those peas are ready, they can get there really fast. And it's like, out of my way, are the peas ready? And of course, once they get to the peas, yes, we do have to help them, because some of them are really had a hard time. But it's just been so fun to watch them, and they just light up. And you can tell by the pictures that it's been a really successful garden. And so why this program? These are, again, are pictures of the garden, but the picture on the right is one that I took when I was in Vancouver on East Hastings Street. And this particular garden, if you know anything about East Hastings, it's the fentanyl capital of Canada. And they say even North America. Many seniors living on the street, many addicted, many overdoses, but they have a garden. They put it in themselves, and this is a big sign, and it's something, it says, no hard drugs in here. Some of us are trying to get better, you know, and it just shows that when they take something, it becomes theirs, and they don't want anyone messing in it. And so why gardens? Because they heal. They feed people and they can heal people. And I have not seen angry outbursts in the garden. So I do know that in nursing homes and long-term care facilities, there's agitation and not sleeping at night, walking the halls. But when they come to the garden, one of the things they've told us, the seniors have told us, is they would like us to change from morning to afternoon, so that they don't feel they have to have their nap in the afternoon. Because if they're busy all morning in the garden, then they want to sleep after lunch. And they said, have us come in the afternoon so, you know, we can fall asleep at night. So we're learning to do things the way we're supposed to. So gardens feed people, and Ron Finley, if you ever want to just Google him, he does gardens in South Central LA. He's hysterical. Growing your own food is like printing your own money, and indeed it is. Not having to pay for food allows for seniors to have some income, maybe not a lot, maybe not disposable, but the ones who processed food from the garden last year had enough spaghetti sauce for the whole year. They had peppers for the whole winter. We put in 600 cloves of garlic. And so we had 600 bulbs come up. So 600 times 5, right, is 3,000 cloves that we could give out to seniors. And it's just, it is money. If you can give, and this fruit is free to them. It's not little spaces like a community garden where everybody has their own little plot. It's the big garden, and they work everywhere. They do what they want, where they want, when they want, and they harvest wherever they want to. Gardens offer non-invasive therapies. There's so much research from the Canadian Horticultural Therapy Association and the American Horticultural Therapy Association that if you want to, have a therapy that is, there's no clipboards, nobody's taking notes on you, nobody's, seeing if you need your drugs changed or these sorts of things. And not that those aren't important, but this is just different. And so it's a self-healing, a place where you make your own decisions. There's autonomy. Nobody's telling you what to do so much. And it's just a non-invasive therapy. Gardens are familiar and encourage memory stimulation, as somebody spoke about earlier, storytelling and imagining, creativity. And family member caregivers, especially, they enjoy something different. So we've had caregivers come to the garden, bringing this woman here has quite severe dementia, but so she would just be in the garden. The Salvation Army community coordinator would spend a lot of time with her, bring her out. We always bring snacks to the garden because if they don't want to eat raw vegetables, they can get, the snacks from inside. And so, but the caregivers have a little bit of time knowing that, the person that they're looking after is being taken care of in the garden. So the preliminary outcomes, so what participants have told us and what we have observed is that they do not want to miss workshops. We have them every 2 weeks and they really correspond with what's going on in the garden. So everything from starting seeds to saving seeds and just the whole cycle. They like getting out, feeling useful, hearing new ideas, giving advice and meeting new people. And they do like giving me advice. They like being in the garden to harvest their own food. They just light right up. Like it's just so crazy to see them pull out the carrots, and it's just so much fun. They do a wonderful job designing, telling us, what meets their needs, and we need to listen to that. So right now we know we need to install more shade and places to rest. Seniors need more transportation. We need to be able to give that to them so we can get them there. And during COVID, they're still cautious, probably more cautious than what I am. And I need to respect that and remember that that may be why some still aren't coming. If they come and they feel that I'm not being as careful as we should be in the garden, then that's going to set them back. And so that's something that we need to be cautious of when we're working in the gardens. And these again are just some of the pictures. One of the things for our knowledge transfer is we promise to do a toolbox that can be used anywhere, adapting or adopting it. So you have to have land, you have to have good resources and a good network. That's to start. And then you need your knowledge and your plan and your volunteers. And yeah, so that's kind of what it is. Thank you very much.
So as Suzanne said earlier, isn't this amazing? So it's my pleasure to thank each and every one of our presenters. And now it's break time. So please help yourself to refreshments and visit the exhibits.